and welcome to the session. My name is Victoria MacDonald. I'm the Health and Social Care Editor for Channel 4 News here in the UK. So good morning and welcome. I was asked to talk about my 18 months or so of reporting on the pandemic and my observations and some of the issues about inequalities that we've come across. When I was thinking about it, I have been a health correspondent off and on for nearly 40 years. And there have, of course, been numerous epidemics, outbreaks and scares. In fact, I began my career in the year they discovered HIV or started talking about it. A gay plague, as they were talking about it then, that swept through communities and countries. And I learned about viruses, mutations, sort of right back in the early days then, of course, but there was nothing like this. So I've been trying to find the right words to describe the impact the pandemic has had on me professionally, because it sounds crass and insensitive to say that it's been exciting and stimulating, which it has professionally, but it's also been frightening and completely exhausting, of course. Going back to what I was talking about, the viruses, I mean, obviously along the way too, there have been things like SARS and MERS and Ebola and H1N1. So to give me a certain familiarity with how this works. But I think for all of us, it was about learning as we went along. And I think all of you out there will have felt the same, you know, daily, sometimes 3-4 times daily, we would be getting new information, some of it contradictory, some things that we thought we knew absolutely at the beginning, now we think isn't necessarily so. When I was looking back on the past 18 months, it's probably more than 18 months now then, actually, I was thinking about March the 3rd, when we were sitting in the Downing Street press briefing with the Prime Minister, who was flanked by the Chief Scientific Advisor, Sir Patrick Vallance, and the Chief Medical Officer, Chris Whitty, who was a speaker yesterday. And it was the last time, I think, just about that we were all in the room at Downing Street. And the microphone was passed to the BBC to ask a question, and then to Sky, and then to ITV, and then mistakenly, as it turned out, it was given to me. Apparently, Boris Johnson had been pointing to the person 3 rows in front. So I asked him, and it was a genuine question. I wasn't trying to trick him at all, or to make him look silly or anything like that. So I asked, Prime Minister, are you still shaking hands? Because at that moment, we weren't quite sure what we were meant to be doing. And to our collective astonishment, he said he was still shaking hands, that only the other night, he said, he'd been at a hospital with coronavirus patients, and he said, I shook hands with everybody. You will be pleased to know, and I continue to shake hands, is exactly what he said. We see the Chief Scientific Advisor and the Chief Medical Officer visibly blanched, and the Downing Street press office later rang around the political correspondents to say that the Prime Minister had not actually been shaking hands with people with coronavirus, and that the scientific advice was not to shake hands. He was, the Prime Minister, of course, later to become seriously ill with coronavirus, although obviously there was no link between the two. I mean, that really does feel like a lifetime ago. In the first few months of the pandemic, I barely had time to breathe. I spent hours awake, reading, talking to experts, reporting, and then all over again the next day you would start again. My daughter, who was then 10, was sent home from school, and I remember laughing somewhat hysterically at the idea that I was going to be able to homeschool her. And she laughed equally heartily at the realization that my distraction meant hours looking at TikTok. I mean, for a start, I never worked from home during lockdown. The job couldn't be done remotely. The story was too fast moving and changing by the hour, with late breaking news to add to the stress. And I think, without wanting to sound too sanctimonious about this, I think many of us reporting this pandemic have felt a responsibility to get it right, to not to scare people and to not get dragged down rabbit holes of conspiracies. We've had enormous help from the Science Media Centre, who organised numerous briefings with some of the finest experts available. But I think what this pandemic will stand out most for me is when I was filming in the hospitals and the intensive care units. So the first one I went to was one in South London, and I have to say I was unprepared for the scenes that we would witness. I filmed around the world and in some pretty grotty hospitals, it has to be said, with some very, very sick people, particularly some of the AIDS patients in Africa. But this was on a different level. These were some of the sickest of sick patients, and this was the early days, so the chances, of course, of their survival was lower than it is now. But what became clear very quickly were that many of these patients were there because they already had poor health, and they lived in poor housing, and they had unhealthy diets, and they were disadvantaged already, and their chances of fighting this virus were already diminished by their circumstances. Now, this wasn't just my observation. The Trust had actually been collecting data, and you could see that a disproportionate number had come from the houses on the main roads in and out of St. Helier, in South London. And it was almost as if, of course, their life circumstances were writ large in their postcode. So the theme of this conference is inequalities, and lying in those beds in that hospital with so many patients who epitomize the stark inequalities in our society. As the pandemic progressed, it became clear too that these inequalities would manifest themselves too for those from Black and minority ethnic backgrounds. And too often these were the people, as we now know, who were forced to continue to go to work, who had to get public transport, who didn't have the luxury of staying home, who also lived in poor housing or had poor diets. And every hospital I filmed in over the following months, it was the same story. Of course, middle-class, well-educated, well-housed people were still ending up in hospital too and were dying, but they weren't the majority of the people I was seeing in those beds. So this was about the UK and looking through the lens on our doorstep. But in March, I then went to Liberia, where they were rolling out a new vaccine for secondary polio. But just before we'd got there, the COVAX consignment had also arrived, the Oxford Astrozenica vaccine, and yet it wasn't being rolled out. It was sitting in storage. In fact, the medical officer in Liberia, it was in Freetown, showed me, opened up the storage. I had this terrible panic that it was all going to be ruined and that Channel 4 News and I would be responsible for losing all their vaccines. But they had a real issue with, I call it vaccine hesitancy. I'm not sure that that's fair, but there was concern in the public because they hadn't actually seen a lot of COVID. Their primary concern actually was that there was Ebola over the border or in Guinea, and they were scared of that, not of COVID. At the same time, the president was refusing to be shown to be vaccinated with the AstraZeneca vaccine because he'd been reading about some of the issues and he didn't want to take it. So it was the sort of perfect storm. And yet here you had almost a country that was almost a sitting duck waiting for the virus to spread. And then, as we know, Delta variant was beginning to spread across Africa by this stage, and yet they were completely unprotected. And at the same time, they didn't have enough of the vaccine. This is a country that is entirely reliant on aid, and the health authorities needed to be able to say, we're going to give you one dose and we can guarantee we're going to give you the second dose. But this was at the stage that India had itself stopped sending the AstraZeneca. So they didn't know where the next consignment was going to come from. And, even as we're speaking, we know that just 2.2% of people across Africa have had that first dose. Only last week, we broadcast a piece from Idlib in Syria, where just over 2% of the population is vaccinated. And of the 7 hospitals for COVID in the rebel-held territory, there are just 124 intensive care beds. The children's ward was full, malnourished babies were dying. And it was absolutely heart-rending. And that then brings me to aid cuts and a piece that I worked on with vets, which was again heartbreaking. I mean, so many times during this pandemic, there are things that just leave you feeling so wretched. I'm going to try and play you this piece for those of you who weren't able to see it. My technological abilities aren't great, so just let me give it a go. Share. And
Our health and social care Victoria McDonald who joins me now. Victoria, what have you managed to uncover? Well, I've been talking to a health training program, partnership program, where NHS staff volunteer their time, go out to rural areas to share their skills and equally bring back what they've learned to help the NHS. Now, that budget has been completely cut. More than £1 million and more than a year is spent already on sorting out this program, which has been widely admired by the government and have been much appreciated, was much looked forward to in countries like Myanmar, which are in terrible trouble. But the lack of transparency means that we don't know why these cuts have been made. And you have to also say that these are eyes on the world for when there might be another pandemic or epidemic. So they are critical eyes and they're gone. The coup, COVID and cuts. Myanmar is already a nation of turmoil. Now a doctor who's in hiding has told us that the slashing of the UK's foreign aid budget has come at the worst possible moment.
So since the coup has started, health professionals, all the doctors and nurses are the target of the military coup. They are issued with arrest warrants for treating the injured protesters. Sometimes when they are arrested, they come back not alive but dead. And at the moment, the COVID-19 has been surging and raging at force, and their testing and the treatment facilities have been stopped, and so nobody actually knows how we are going to tackle this.
£9 million was to have been provided to improve trauma, children's cancer services and nurse training. 7 million of that would have come through the UK Partnerships for Health, a programme set up by the Tropical Health and Education Trust, known as NET, and Liverpool School of Tropical Medicine.
Unfortunately, these expectations have been let down, and there will be a huge repercussion from cancelling of this fund.
This letter to the Prime Minister from MPs and peers asks for the vital support to Myanmar to be continued. They say just a month earlier they had been assured the Health Partnership Programme would not be affected by the cuts. There has been no reply. In all, £48 million has been cut from the global health training budget.
My right honourable friend, the Chancellor, updated the House yesterday on the economic challenges posed by COVID-19. It is a truly sobering assessment.
The official development assistance budget, he said, was to be reduced by £4 billion. What the government hasn't made clear is where these cuts might fall. In fact, it even refused a freedom of information request to give some detail on the areas of the programmes that could be impacted. Inevitably, though, details are starting to leak out, and the cuts, they are widespread. Work in Uganda to reduce deaths from sepsis in new mothers. The £300,000 funding has now gone.
We have these huge plans to take this further and really try and improve the outcomes for pregnant women and babies in Uganda and to try and promote and improve the numbers there. So we feel it's taken a big step back in what we're able to do, what we're planning to do. It's going to take quite a lot of time and planning to try and get around those.
Everyone involved in the partnerships has pointed out to us that this aid also benefits the NHS and its staff.
some work we've done in one of the African countries, developing packages to teach nurses high dependency skills. How do you look after very sick patients? Was developed for work in local country. On the London hospital, we took that package, but rapidly developed their non-high dependency staff to look after the high dependency COVID patients. The innovations come back through the NHS. It is not one way.
The Foreign Commonwealth and Development Office said we will still spend more than £10 billion this year to improve global health, fight poverty and tackle climate change. We are working with suppliers and partners on what this means for individual programmes. The UK Partnerships for Health Systems has, however, not yet been contacted by the Foreign Office. Sainsbury's quality you expect is now price matched to
Sorry.
just £3.49. With fresh kale only 63p.
So sorry. Can give you a blast of Sainsbury's advertising. I think that says a lot, but you all would know better than I do about the impact of those cuts and how people, how this government still actually, I don't think, has justified how they made those cuts. Anyway, that is enough from me. We have three magnificent speakers, and then we would like to hear from you if you have any questions. So with me, as you can see on the screen, Dr. Manal Ahmed Gas, the Somaliland Ministry of Health Development, Dr. C. Thura, who is at the forefront of running healthcare services for Myanmar's ethnic minorities, and Professor Mala Rao, who has made a very distinguished contribution to addressing racism in the NHS. And they will each be talking on their subject. So can I please hand over with pleasure to Dr. Thura?
Thank you so much, Victoria. Good morning and good afternoon, everyone. And thank you all for being here. I'm honored to have this opportunity to speak to you today about the situation in Myanmar and some of the work we have been doing for the COVID-19 response. This year has been the hardest in living memory for most of my friends, colleagues, and family, as our hopes for continuing transition to democracy were crushed, compounded by the devastating wave of COVID-19 in July, as you briefly saw in the video clip by Victoria. So my name is Sithara, and I'm Executive Director of Community Partners International. Just a brief introduction to my organization. CPI is a US-based organization. Though there are programs in Bangladesh for Rohingya refugee crisis and in Thailand for migrant populations, Myanmar has always been our strategic focus since we were founded in 1998. Our main focus thematic areas has been in 4 areas: health and nutrition, humanitarian relief, sustainable community development, and research and innovations. So I will try to give a little sense of what has happened, where we are now, what steps we health professionals will need to consider in the upcoming years. First, some background about my country. Being one of the most ethnically diverse countries in Asia, Myanmar suffers the longest inter-ethnic conflicts in modern times. Military ruled the country since 1962 to 2011, and there were 2 quasi-civilian government terms between 2011 and 2021, and the military staged unjust coup in February this year. For several decades, people in the ethnic conflict-affected areas were in dire need of the basic health and social services. Talking about the COVID-19 situation in Myanmar, a first COVID-19 case in Myanmar was identified in March 2020. Despite the shortcomings of the health systems, I would say the country was able to minimize the consequences due to COVID-19. The NLD government, led by Daw San Suu Kyi, responded the situation in the whole of society, whole of government approach The political leadership by Daw San Suu Kyi was crucial in the different dimensions of the COVID-19 response, ranging from risk communications and community engagement to resource mobilizations. So the government ministries, private sector actors and civil societies work very closely and harmoniously last year. And COVID-19 vaccination program was launched in January 2021, just before the coup. That's one of the earliest programs in the region. Unfortunately, the Myanmar's military seized power in February, disputing the election result held last November, in which the civilian government won resoundingly. So it has been more than 8 months now since the coup in Myanmar. During this period, we have seen the widespread protest, conflict, violence, and the instability triggering a humanitarian crisis. The country is now experiencing, as you may have seen in the news, mass demonstrations, brutal crackdowns, internet shutdowns, and the media repressions, the paralysis of the government services and the banking system, a widespread violence, and the escalations of the conflict with ethnic armed organizations, and even with the local people's defense forces in many parts of the country, and looming economic collapse as well. So on a personal level, as a citizen of Burma, it is horrendous to see the country falling apart. So much of the progress made in the last decades has been lost. We are sliding further into the abyss each day. Pro-democracy civilian leaders are under arrest or now in hiding. The security forces are everywhere, arresting people at will, checking phones for the evidence of the pro-democracy activism. And nobody feels safe, and our rights and freedoms has been crushed. It is heartbreaking whenever I think about the children of my country. Now their future looks totally bleak. Since the coup, the members of the medical profession have been at the forefront of the anti-military protest and the national strike of public workers, known as the civil disobedience movement. In retaliation, the military occupied medical buildings and hunted down, arrested, and imprisoned health workers. Many thousands who joined the CDM are still refusing to cooperate with the military up until now. So magnitude of the COVID-19 first and second waves in Myanmar were relatively small, and vaccination rate is low. So the immunity of the people against the COVID-19 is pretty low. And the new Delta variant spread much faster than the previous variants. These two factors reinforce each other, and that leads to a very rapid surge since early June 2021. So the graph you're seeing here is the official data from the de facto authority. So even with the under-reporting and the limited capacity of the lab facilities across the country, we saw the positivity rate around 20 to 50%. So as we all know, the COVID-19 really nicks down even the sophisticated health systems in developed countries. For the country like Myanmar, especially at this period of time, it is extremely disconcerting situation. During the peak, the public hospital cannot accommodate the increasing number of patients. What I am seeing on the ground in the past few months is quite heartbreaking. So families desperately looking and seeking oxygen and care for their loved ones, and queues of the people forming the tracking the oxygen from unconfirmed internet sources, leading doubtless to further viral spread. So people dying in their homes, and mortuaries and crematoria overflowing with the dead. So in this appalling situation, Community Partners International, we started to think about what we can really do. So we plan to target to 80 to 95% of the patients contracted with the COVID-19 who can be categorized as mild, moderate, and severe cases. At the same time, we are also cognizant of our limitations in current situation. like security concern, particularly harassment by the security forces, and limited human resources and the availability of the medicines and supplies in the market at that time. And from the aspect of our strengths, the partnerships, we have an extensive network of partner organizations, ranging from small community-based organizations to international organizations and agile operation systems. And our previous experience in first and second waves response, and our office in the border in Thailand for necessary procurement and medicines and supplies. So I will finish with a short summary of some of the approaches we have been taking. And CPI has spent the 2 decades in close partnership with the vulnerable communities and the most challenging contexts all over Myanmar and across the borders. Neither we nor these communities are actually strangers to conflict and crisis situations. We work in close partnership during the previous period of military rule. So we are drawing on these experiences now. So this is built into CPI core operating model. We rarely deliver services directly. Instead, we believe in local partnerships, and we support communities themselves with the leadership and service delivery systems, training and supplies to build and deliver the essential services that they need. So this partnership model has proven itself much more resilient to the various types of shocks throughout the history. So it doesn't rely on us being there. And the community-based organizations we support are people you can rely on never to abandon their station when the going gets tough. So this doesn't mean that it has been so easy. We typically distribute the lots of medicines and humanitarian supplies to our partners. We have seen rogues block and the medical supplies confiscated at the military checkpoints, and banks have limited withdrawals, and cash has been scarce, and the border are closed, meaning that importing has been difficult. And in addition, like communications has been hard as the mobile phone networks are monitored and quite patchy up until now. But with the partners dedicated to providing services to their communities and knowing ins and outs of the changing restrictions day to day, we have managed to keep things moving. So we have adopted a strategy, which is a multi-layered approach, ranging from telehealth consultations to the treatment centers and supporting treatment center and the oxygen banks across the country together with our partners. So within July to September 2021, we estimate our combined response with our partners is reaching more than 900,000 people across the country with COVID-19 preventions and care services. This is a dashboard of our COVID-19 response starting from July. So we have a lot of direct evidence that these activities are helping to save thousands of lives. So as well, COVID-19 response, we are also working to sustain the other health and humanitarian services we support in a COVID-19 secure way. So what we can learn here, where should efforts be targeted, at least for the short term from Myanmar? So prior to the coup, we were actively engaged in efforts to usher in universal health coverage in Myanmar. Now that seems like a very distant memory. Realistically, we don't expect the situation to improve anytime soon. Most likely, it will get worse in the short to medium term. So this sadly means health outcomes will almost suddenly worsen. However, some of the soaring needs can be met. Here, I would like to offer you a few thoughts. First, the implementation model, working through partnership with the local organizations, has proved to be valid now more than ever. So amidst the daunting challenges, without the contributions from our local partners, we won't be able to reach people in need on the ground, of course. And secondly, we believed that our approach in long-term approach in capacity development and the empowering the local communities really pay off at this critical juncture. Despite the huge challenges we faced, building their capacity leads to huge gains in resilience that neither international organizations nor governments alone can provide. So thirdly, active engagement and the participation of the community played a critical role in response to the crisis situations like this. Without the engaged communities and the citizens or people-centered approach, none of our effort will be utilitarian. And finally, the humanitarian assistance the needs in Myanmar will be graded. It is critical to retain the international community's support to Myanmar. Over the past 8 months, amidst all the challenges, the people of Myanmar have demonstrated their resilience and dedication towards the democracy. So I believe that the people of Myanmar deserve your continuous support, especially in the darkest time of the country's history right now. With that, I would like to conclude my section, and thank you so much for your attention. Hand over back to Victoria.
Thank you so much. It's very powerful, and in the first of what we're calling the postcards from an unequal world. Could I now introduce Professor Mala Rao, who, as I said earlier, has made a very distinguished contribution to addressing racism in the NHS. And if I could hand over to you, Professor Rao. Thank you.
Well, thank you so much. Thank you. I'd like to begin by thanking you, Victoria, and Ben Sims, the CEO of SET, for inviting me to give a talk on the year that was Insights from an Unequal World. My aim today, and it's a true honor, is to share with you my views and perspectives from England, from the NHS, on the ethnic inequalities exposed by the pandemic, why race equality matters, and the crucial role we all have in contributing to this goal. Next slide, please, Kieran. History will remember 2020 as the year when two events collided, resulting in turmoil worldwide. I am, of course, referring to the COVID-19 pandemic and the killing of George Floyd in the US, which resulted in an eruption of anger, pain, and grief, and a massive resurgence of the Black Lives Matter movement across every continent. And as countries and communities grappled with the challenge of these two tsunamis, the link between the seemingly unconnected issues began to be understood, and the world woke up to the fact that the disproportionate impacts of COVID-19 infection on ethnic minority people is explained in substantial part by the racism, discrimination, and socioeconomic inequalities which have defined their lives long before the onset of the pandemic. Next slide, please. The national landscape, next slide, please, Kieran. The national landscape is one of widening socioeconomic inequalities, and the Health Foundation rightly entitled one of its reports, I don't know if you can see the little frame on the top right-hand side, rightly entitled one of its reports, "The Same Pandemic, Unequal Impacts." But the starkest evidence which began to emerge, previous slide, please. But the starkest evidence which began to emerge early in the pandemic was that people from ethnic minority communities were likely to be at increased risk of acquiring the infection, as Victoria pointed out in her talk, and that Black and Asian patients were overrepresented among those critically ill with confirmed COVID-19 receiving advanced respiratory support in our intensive care units. So what do we know about the disproportionate impacts? People from ethnic minority groups had higher rates of death when compared with the white population in the first wave, The rate of death was highest for Black African people. And in the second wave, the Bangladeshi group had the highest death rate. Next slide, please. The impacts on NHS staff too has been absolutely devastating. And even as early as by April 2020, 63% of staff fatalities were already noted to be of ethnic minority origin. And as of now, 86% of doctors who have died are from ethnic minority backgrounds. The majority are international medical graduates, the diaspora in the NHS. Next slide, please. So what explains the differences in the risk of mortality between ethnic groups? If we look at what the Office of National Statistics concluded from their analysis, it was that a large proportion of the difference could be explained by demographic, geographical, and socioeconomic factors and pre-existing conditions, but it did not explain the remaining ethnic background difference in mortality. And Public Health England's report, Beyond the Data, went further in acknowledging that its stakeholders who had been interviewed pointed to racism and discrimination, and that ethnic minority NHS staff may have been less likely to speak up and demand personal protective equipment despite such a grave risk to their lives. Next slide, please. There is a mountain of evidence. Next slide, please, Kiran. There is a mountain of evidence published over at least 3 decades, highlighting, and I've just, I've inserted the front covers of some of the books and the reports that have been published, that racism has pervaded the medical workforce, and it is for this reason that I will focus on doctors for the rest of my talk, although it is my view that the challenges are likely to be similar in all of the other health professions. Doctors from ethnic minority backgrounds face disadvantage throughout their careers. We know that from the evidence. Differential attainment by ethnicity persists across all measures of career progression, the entire training pathway, and in all medical specialties. They are underrepresented in leadership roles. They earn less. They apply for more consultant jobs, but are less likely to be shortlisted or be offered a post. They face double the rate of being referred to the General Medical Council, our medical regulatory authority, by an employer, more likely to have their revalidation, which is the 5-yearly review to renew your license to practice. So they're more likely to have their revalidation deferred, to report higher levels of bullying from staff and colleagues, and lower levels of belief that their trust offers equal opportunities for career progression. But despite all of this, the NHS staff surveys tell us that they report higher levels of motivation and engagement at work. And we could discuss this later if time permits. Next slide, please. International medical graduates, the diaspora, experience the worst levels of disadvantage, although the NHS has always relied on them to prop it up. International medical graduates make up 28% of all UK doctors, at nearly a third. And in 2020, there were more international medical graduates who were joining the GMC register than even UK-trained doctors. But despite that, they're treated with indifference at best and often work in the most undesirable roles, unpopular rotas, and geographical areas, are perceived as gap fillers and used to be moved around as locums and single-handed general practitioners in rundown premises in past decades. Next slide, please. Furthermore, the British Medical Association's own analysis shows that international medical graduates face the challenges of a complex and costly immigration system in this country, living in a new cultural environment which may not be friendly, joining an overstretched NHS, carrying some of the heaviest workloads, adjusting to a new workplace culture with little support, inadequate induction, cultural barriers, and indifference which make friendships hard to establish, and all the while they are far away from family, friends, and support systems. Next slide, please. You may ask whether race equality matters. It does. And there is not just a model case. but a very sound business case to be made for race equality. Ethnic minority people have a greater burden of ill health. The health survey for England as far back as in 2004 showed that the health of white English people aged 61 to 70 is equivalent to Caribbean people in their late 40s or early 50s, Indian people in their early 40s, Pakistani people in their late 30s, and Bangladeshi people in their late 20s or early 30s. Population research ignores ethnic minority people. Only yesterday, the Secretary of State for Health said that medical devices needed to be checked to ensure that they work well for people of all ethnic backgrounds, because there is evidence that they may not have been tested across diverse communities. Ethnic minority participation in COVID-19 National Institute for Health Research funded studies was low. And although more than 9 out of 10 adults are positive about COVID vaccination, vaccine hesitancy remains highest in some ethnic minority groups. Could this simply be following historic trends of lower flu vaccination rates, which apparently have occurred in these communities, but which the health service was indifferent towards in the past? The evidence points, does it not, to the fact that ethnic diversity and racial concordance plays a positive role in health care and in enhancing trust and cooperation between racially concordant doctors and patients. So wouldn't it make sense if the system enabled ethnic minority doctors to achieve their full potential in healthcare delivery as well as in research, because they could be such efficient ambassadors and effective ambassadors, building bridges between the system and the community? Next slide, please. So furthermore, NHS staff surveys are carried out across the hospital trust annually. And what they demonstrate very clearly is that the extent to which an organization values its minority staff is a good barometer of how well patients are likely to feel cared for in that organization. There's an almost linear relationship between the two. And the evidence from industry is even more compelling. McKinsey's series of 3 studies across 15 countries and more than 1,000 large companies investigating the business case for diversity demonstrated its links with profitability, with an even higher likelihood of outperformance with ethnic diversity than with gender diversity. It also showed that the likelihood of financial outperformance is now in 2020 even stronger than it was in their 2015 report. So next slide, please. In conclusion, real change requires radical, courageous, transformational actions with our white allies and ethnic minority staff working together. The challenge is for all of us, for everyone, to recognize that race equality is everybody's responsibility and everybody's business, and a crucial means to achieving the highest quality of patient care, so that when a pandemic strikes, we're all prepared and we're all working together to achieve our best by our patients. Thank you so much for listening.
Thank you, Professor Rao. That's fascinating and disheartening in many respects. It's a discussion that's been going on for decades and decades in the health service. And I think the first time I reported on the Snowy White Peaks report must have been about 20 years ago now. And I'm feeling that nowhere near enough has changed. Maybe the pandemic will bring that more into, shine a stronger spotlight on it. Can I now please introduce Dr. Manal Ahmed Gas, who is the Somaliland Ministry of Health Development. Thank you, Dr. Gas. Oh, you're muted.
Thank you very much, Victoria. I hope now everyone can hear me well. Okay, my name is Dr. Ahmed Gas. I'm from Somaliland Ministry of Health Development. I have been working in the front line of COVID-19 since the beginning of this pandemic, which is basically from 2019. But actually COVID-19 hit us in Somaliland the first time in 2020, March. That was our first reported case. So we didn't struggle with COVID-19 until then. The topic our today insight is insight from an equal world. We had our share from inequality, and COVID-19 has been a very difficult struggle that we have struggling for the past 2 years. We had it worst in this Delta variant, which is actually happened in Somaliland for the past 3 months. So our death rate was very well controlled, between 90 to 100 for the past year. And from last July, the end of July and the beginning of August until today, which is the 8th of October, our death rate was 498. That has multiplied multiple times, which is a 100% increasement rate from what it was before. Saying that, we did that Delta variant, even though we had vaccinating people left and right, and we were trying to manage the best of our ability. The COVID-19 is some new pandemic. No one knew how to handle it, and we were the first of those people who actually had no idea how to manage it. But from the help of an international societies and from an expert physicians and just the treatment guidelines we have developed, we were lucky to have it under control for the past year. The first time that the COVID-19 hit us, we didn't have those many cases, but what we had was a kind of societies, the people panicked from a disease that was unknown. And as the social media and everywhere on the news was telling the people had a 5% mortality rate, and that the people above 80 has the high risk, that's actually created the more panic in the Somaliland society. What we had the trouble with, that people were needing a mechanical ventilator, and we were barely struggling to have an oxygen cylinders for the patient, let alone a mechanical ventilator. So for us, if the patient needs an intubation, that was it. We couldn't do anything more. We had only 4 mechanical ventilators in Somaliland by the time the pandemic began. Only 4 for 4 million people. That is like less than 0.01% chance of survival rate if you needed a mechanical ventilator. We couldn't handle that. So we have decided for our treatment guidelines to stop at the stage of mechanical ventilators. That was it. That was all we could do. Because we were struggling alone to provide the oxygen for the patients. We were using the cylinders, we were using the oxygen concentrators, and that was not enough for the patients. We had a lot of help from the international society, especially WHO, UNFPA, UNICEF. They have provided multiple oxygen concentrators, but as you might know, if there's any medical people, doctors or clinicians, oxygen concentrator cannot raise your oxygen saturation rate by more than 15% of what you need. And by that time, we needed for the people to have 100% oxygen, or at least the minimum per amount was 95. So that was our biggest struggle. We had only 1 oxygen implant in the whole city of Hargeisa, which is the capital city of Somaliland, for those of you who doesn't know. For that only oxygen for only that oxygen implant, which could produce maybe 300, 400 cylinders per day, and one patient can consume more than 20 or 30 per day, depends on his oxygen needed. That was the most difficult struggle we had, was with the oxygen. Luckily now, with the help of international society and the government, we have 6 oxygen implants in Somaliland, which basically every region has its own oxygen implant by now. And that's such a great milestone for us. At the beginning of the pandemic, the first place that we had the testing facility set to us was the Hargeisa Group Hospital, which is the national referral hospital for Somaliland. Hargeisa Group Hospital is the only referral hospital, or the main hospital national we have in Somaliland, and it can comprehend. Its capacity is around 400 to 450 inpatients per inpatient, that's its capacity, and it's used to say more than hundreds of patients in the outpatient department. But since it was set up as the COVID-19 treatment center first, it wasn't actually the treatment center, but it was the testing for COVID. It was where the PCR was set. So this compromised the basic or primary health care, because people were very scared to go to the hospital to have their basic checkups, their routine surgeries. Maybe people with hypertension who was on a regular schedule. Even mothers were delaying their prenatal and antenatal care. Everything became delayed, and even the outpatient department of Hargeisa Group Hospital was shut down because people couldn't come in anymore. So we tried to focus on the primary healthcare by promoting the MCHs to provide at least the basics of the healthcare that we could. And then doing that, we had a grant that was provided by TET and was co-managed by King's College. We did a COVID-19 response grant for Hargeisa Group Hospital, and we set up actually for the outpatient department to facilitate and call or telemedicine. So every patient, we were at least trying to ask patients to call in to give them the basic of medical help. And if there is, even if the patient needed some emergency care or something, we would tell him where to go, what to do. So this was something that we have done, and I hope if some other country was struggling from the same situation, they might learn from our experiences. If we come to the vaccine department, sorry. If we come to the vaccine department, the first dose that we have received from AstraZeneca was provided by WHO and UNICEF partners. We first received 65,000 doses, only 65,000 doses. And as I mentioned, the population of Somaliland is 4 million people. So this actually was like, people were worried, if I take this dose, do you have a guarantee from where could I get my second dose? That was the main question we couldn't answer. But like the partners were there and we were assuring people that they might get it, and that wasn't a problem. And actually the fear, the population fear actually came to a reality where the second dose that Somaliland was only 30,000. So 65,000 doses were given, but only 30,000 people, which is almost 50% of people, half of the people who took the first dose cannot have their second dose. And that was just a harsh reality for the government, for us. And after that, the COVID-19 and COVID-19 Shield Center for India that was made in India was shut down, as you all know, and Victoria mentioned. And that was like very worrisome for us. It was a very problematic and something that we were actually worrying about. But luckily, the WHO and the International Society again stepped up for our help, and we have received another 90,000 doses that are currently being distributed here. But in total, the doses that we have as an AstraZeneca is 185,000 doses that have been received from March to now, to August, which is in 5 months. That's only, even if the doses is giving 100% in, that's only 4.6% of the Somaliland population being vaccinated. And that's the most inequality of things that we have said. So as a government, we have to prioritize who should get the vaccines first and who shouldn't, because we can't have the 4 million people to get vaccinated. So we focused on the elderly and on the main cities that are crowded. So as if you don't know, let me give you a background on Somaliland situation. So as I mentioned, there's 4 million people of Somaliland. 33.8% of our population are nomadic people. Nomadic people, which means they might move from place to place depending on the rain or anything. 11% of the people are in rural areas, and only 52.9% of our population are located in urban society. So we have prioritized to focus on the urban society and to cover as much as possible, because, and let me explain this, why did we came to this rationale, which was mainly because the cities are more crowded in general than the other places. The cities are more crowded. For example, only in Hargeisa, the population people are almost close to 1 million. So we are prioritized to focus on the main cities. We did provide some in the rural and nomadic area, but not much. Maybe 20 to 30% of what we had was given to the rural areas. Out of the 70% that we were giving to the urban society and the cities were elderly, the people who were always in high risk of developing the severity symptoms of COVID-19, which was people with diabetic, hypertension, any comorbidities or chronic illness, any people who has the COVID-19, any people in general for the COVID-19 WHO guidelines that says that they are high risk. So this is what we supposed. The main inequality is this. When I was doing research for this project, for this specific talk, I have found out, and please correct me if I'm wrong, that 60% of UK population were vaccinated. And even in the United States of America, it's almost close to 65%. That will be more than 90 million or 60 million doses of vaccines, where we are struggling still to have only 4 million doses. And not everyone is pro-vaccines. There's people who are anti-vaccines, so no one can vaccinate the whole community in a while. There's people who are against it, there's people who support it, so there will be another kind of issues that will always be an issue. Not being able to provide the option of having for the people to at least have that vaccines and to be protected is something really devastating for us. That was all. And mortality rate is currently rising so much. Like, as I mentioned, in the past 3 months, the mortality rate for the past, like from 2020 March up to 2021 July, we only had 98 death recorders for the COVID-19. For this past 3 months only, that number has increased in 300. So we have currently 498, almost 500 people have died for COVID-19. And that's only the reported cases that we had. Because there is this stigma of testing for COVID-19. As a Somali people, we are a much religious people. So one thing that was really something untouchable for the society was the burial methods. And as COVID-19, if the patient was dying from COVID-19, the government has to bury them, even though we allowed the family members to attend the burial sites after that. But since just to limit the I'm sorry, just to limit the exposure of the disease, we have there was some sort of people that were handling only the grave digging and the burial sites. And for Somalis, this was a ritual that was very respectful. This led for people to not report as much as they wouldn't like. So people wouldn't, we know that patient is positive and was in home care, and they wouldn't tell you if the patient died just because they wanted to perform the burial by themselves. So as a government, the Ministry of Health, we saw this was the main problem, that people were not coming forward with the disease or testing. We had them, we were providing the PPE for the family members to perform the burial themselves. So this was some kind of the gestures we have made. Thank you very much. Back to Victoria. If you have any question, you may ask.
Thank you so much. I wanted to ask you actually how your country feels when you know that the UK, for instance, and other countries are already giving booster shots when you haven't had enough vaccine to give primary shots.
Yeah, that's, as I mentioned, that's very devastating for us. When we are the government, we are responsible of the people and providing the vaccines, and only 4% of our national income is being located for the health department, because we were all depending on the international society's help. So this was something we couldn't comprehend in our mind, and our hands were tied because we don't have the budget for it. We were struggling enough for buying the oxygens, for providing the basic health cares that people need. Not being able to provide those kind of vaccines while countries giving their boost shots are just, this is the definition of inequality in the world.
Yes, I think many people would agree with you on that one. We have some questions. We've been allowed to extend the session because it's been so interesting, and I hope our speakers can just stay on for an extra till 10:15, if that suits you. There are some questions in the question box. If you, our audience, our unseen audience out there, if you have any questions yourself, just pop them in the Q&A box, and we will try and get to them. Dr. Sichura, there's one here for you. Says, fantastic work in such difficult circumstances. I'm interested in the community partnership model. Are those you support healthcare workers or lay people? And in which case do you support with training?
Sure. Thank you so much for the question. So it actually depends on the partnership that we establish. So as you can see, like, in my dashboard, we have been partnering with the about 49 organizations, a very wide range of the organizations, ranging from like a small community-based organizations composed of volunteer workers who are the lay workers, up to the professional association. There are different wide range of the organizations. Depending on that, we have been supporting and deploying with the required medicines and supplies to the different organizations. For instance, like for civil society organizations on the ground, they might just have a volunteer who might be the lay workers, and maybe we are going to partner with the faith-based organization or a local NGOs where they deployed the Medicare doctors and the nurses. And in addition to that, we also have a very long-standing relationship with the ethnic health workers. It is quite unique for Myanmar because of the over 60 years of the conflict. The different ethnic organizations have different local ethnic health systems where they have a different source of trainings. So it is not exactly the same like a Central Burma, public health ministry, but it is the equivalent of the midwife, local midwife, and they have their own training systems. And so we refer to them as ethnic health organizations, and they have a separate cadres different from the Ministry of Health in the Central Burma government area. And so depending on that, we have a different wide range of the health forces on the ground. And depending on the organization situation, we customize our package of support. Talking about the training, we developed a user-friendly sort of in Burmese language, result limiter secting, how to manage the COVID-19 patients. So ranging from how to use the oxygen concentrator up to the treating the severe cases of COVID-19. So it lots depend on the partnerships that we have. Yeah, wide range of the organizations.
Do you have issues with continuity given the disruptions in the country? Are there any occasions where you're doing this training and then you lose those people? Or is there a relative stability to these training programs?
For the training program, that has to be quite opportunistic for us. We have to seek every possible way. Sometimes we cannot do the direct training, unfortunately, especially for the ethnic conflict-affected areas, because obviously they don't have enough bandwidth for the internet to do online sort of trainings. But what we are doing is they have some areas they can have access to the 3G, 4G network, and then they have a master trainer, and then in turn these ethnic the trainer, they travel to the 5 or 6 clinics within 7 days to deliver the messages we deliver. And so it lots depends on the areas where we are talking about. It lots depends on the capacity of the organization. In most of the cases, we have to rely on the internet connection, unfortunately. Yeah.
Professor Rao, we have a question here for you. What would you like to see change in the health partnership community to promote equity and valuing of the diaspora NHS staff?
Well, thank you, Victoria. That really is a good question. One of the things that I wasn't able to mention in my talk is that it's quite extraordinary the extent to which diaspora are excluded from research and partnerships. You'll find that many of these opportunities are more likely to be given to, or it's just it's not that is partisan. It's the issue of where there is much more confidence among the white senior healthcare staff to go and lead such a partnership, and not quite that level of confidence or inclusion among diaspora. And so it's quite extraordinary how low diaspora engagement and partnerships might be, even with their own countries of origin. You know, I am of Indian origin, and it took absolutely decades and decades before, although I longed to be part of partnerships where I could try and bridge build between India and Britain and bring in frugal innovations from India to Britain and take back, things that I'd learned in Britain to India. There were not the opportunities, and I was not included. I was not invited. I was not part of those networks until very recently. Things are changing. But I think that's one powerful way by which bringing in diaspora will further enrich and strengthen partnerships in exactly the way McKinsey has found businesses are stronger for bringing diversity into and enriching their thought processes and their planning with different cultures, different ideas, and the innovation that people bring from their cultural contexts and backgrounds.
Thank you. There's another question for Dr. Gass. What has been the role of faith leaders in advancing prevention methods and safe burial practices? And that reminded me of the Ebola outbreak, sort of about the importance of changing the burial practices without upsetting the community.
Yes, that's what actually we have been doing. The elders or the faith advancing, or what we call them as sheikhs, have developed this guideline for the community. So previously, as I mentioned, the people who were performing the burial were from the government. They were they all followed the proper protocol for us to follow. But people actually, as I mentioned previously before, people in Somaliland or in Somali people in general, this is a very, very ritualistic thing that they respect beyond anything. So what we did, that we trained everyone for an hour or 2 hours what to do or how to do the burial and how to protect themselves. And the sheikhs or the faith leaders has helped us a lot in that area.
Sorry, forgot to turn off the mute. Did you receive any advice from the WHO? There's another question we've got here, or other global organizations about the vaccination program.
Yes, WHO and UNICEF has collaborated to guide us and give us any specific guidelines that we had to follow. As any of the international community, we had to follow those guidelines.
Dr. Sithura, there's another question here asking about what more the international community, health community, can do to support the efforts of the health workforce, which I think is an important question, isn't it?
Yeah, thank you for that question. That's really, really critical. And I guess I will respond in a way two layers. One is the policy level. We have been seeing lots of statements and endorsement from the international health community following after the coup, protection of the medical professionals and that kind of stuff. And so I would like to request that, we really need a sustained sort of advocacy, especially for the protection of the rights of the people, health as a rights for the health as a part of the human rights. And so we need that sort of sustained advocacy to create a medical platform that can protect to the medical professionals. That is missing right now. I think, we really need international health community to stand with us in solidarity. So there is a policy level part, and the other thing is the people level. Like, if we are talking about the health services, unfortunately, the military regime, they are always cautious about the international organizations and large, organizations, the operations and everything. And so the role for the large operations, became a really a tight sort of like, space for the time being. So in that juncture, I will just repeat the title of this conference, The Power of Partnership. So in our case in Myanmar, please partner with the local organizations. Please support financial, and you can support financially or technically, and create the enabling environment for the local organizations. As I mentioned earlier, ranging from the community-based organization or either faith-based organization, they have a mission to provide these kind of medical services, and also the ethnic health organizations, and let them do their works, and they know about the nitty-gritty and ins and outs of the local situation. I think that there are two levels. These are the two levels I would like to recommend from my experience here.
I'm wondering, Dr. Manal, whether that gives you any ideas, whether it gives you, whether you feel you can utilize some of this.
Yes, it's actually a very great idea, and it will be great helpful for us if we use this. Thank you very much, Dr. Thura.
Okay, we've got time for probably just this one last question, which I will put to each of you, from Ben Sims. It's important, he says, that we understand the problem, that we face the inequalities before we rush to talk about the solutions. But I'm interested in whether the speakers feel optimistic about the future. A risky question, he says, of course, and also a question that could have quite long answers. But if you could just give me a couple of lines each on should we start with you, Professor Rao?
Thank you, Victoria, and thank you, Ben. My short answer, Victoria, is yes. I feel hugely optimistic, and you were talking about how from tragedy comes hope. The pandemic has been an absolute tragedy, and I tend to think, well, let all those doctors and nurses and porters and everybody in the NHS who died due to COVID not have died in vain. What it has done to everyone else is given voice. It's been so stark. It's exposed the inequalities in such a grim way. You can't put that back in a box and pretend it didn't happen. And it's given voice to the diaspora, the ethnic minority community, and action is happening. We haven't had the chance to talk about that. Maybe at the next conference we will. But there is lots going on, and I feel very optimistic that in 2 or 3 or 4 or 5 years' time, we will see demonstrable progress in race equality in this country. Thank you.
When I was going around the hospitals, one thing that I noticed was all of them were taking copious notes about the things that had worked during the pandemic, the lessons that they had learned that they could use post-pandemic, whenever that will be, so that they didn't forget those lessons. And I felt quite heartened about that, because that learning mustn't be lost. Dr. Manal, how optimistic are you feeling?
I'm feeling very optimistic because we have come a very long way to back down or to go backwards. Compared from when I was going to medical school, for example, my father had died in 2015 for lack of oxygen. Basically, that was all he died. That was the cause of his death, basically because we couldn't find an oxygen for him in the right time. But now, once we have 6 implants of oxygens in the Somaliland region, I'm very optimistic in the future because we have come a very long way. And I'm hoping after 10 or 5 years, we are going to be way much better than where we are now, hopefully.
I like finishing on optimistic notes. So don't let me down, Dr. Situra. Give me something optimistic.
Well, yeah, I think, as you know, the situations in Burma is very fluid for the time being. It's quite unprecedented challenges. It's the darkest time in our history, I would say. Having said that, I would say that, like, the current the level of unity that we have been seeing across the different ethnic minority groups and the people, and it has been a really humbling experience to see the unity across the ethnic organizations supporting to this democratic movement. It is quite humbling. So I still believe that it's going to be really a hard time, but I'm not losing my hope, and I believe that we are going to overcome the obstacles in near future, and then we will be returning back to the democracy and the fighting against the inequality in Burma. And this time, I believe that because of this unprecedented unity that we have across the different ethnic minority groups, including Rohingya. And I think this time is going to be the real change that we can be hopeful. Yeah.
Well, I think we watching from here all really hope that too, actually. We worry. But I don't want to spoil the optimistic note that you have all very kindly finished on, and thank you, Ben, for the question. I mean, this session we were talking about postcards from an unequal world. Well, these were more than postcards. These were very important messages that I think all three of you made and have got across so eloquently. And thank you for making it so easy for me to chair the session. I'm afraid we didn't quite get to all the questions, but your time is valuable, I know, and just thank you to the audience too for the questions that you ask. Enjoy the rest of the conference.
Thank you so much, Victoria.
Thank you.
Thank you too, Victoria.
Thank you very much.
Bye-bye for